good, sure, thank you. Yeah, no, it's cool.
Great.
Great. So, thank you very much, Professor
Thank
Jaron.
you. Do you hear me? Yes. Okay, good afternoon. I have to express my joy to being again at the ARDD, to thank the organizers, and to express my honor to be able to talk to you about hormone replacement therapy, why, when, and how. Now, if you had the luck to listen to Professor Tzipi Strauss this morning, who presented our longevity center at the Sheba Medical Center, you heard that we have 12 different stations where every participant is going through. One of them, which I think is very, very specific, is the one where we evaluate women's and men's health. And I think that this is one of my tasks to persuade you of the importance of it. Let me ask you, are there any gynecologists in this room? Please raise your hand. 1, 2. I think this says everything, because I'll show you that gynecologists and longevity are very, very important. For example, if you look at this slide where we showed, which is not very surprising, that there are differences in many parameters between men and women who come to our clinic. And so if you ask, wait a second, what's a gynecologist doing with longevity? First of all, you know that more than half of the population are women. Second, you know that with age, more and more women make up the population. And third, what I'll show you, female and male longevity are totally different and therefore need to be focused in a totally different way. So first of all, let me answer my first question. Why hormone replacement therapy is necessary? You all know this graph. A woman has the maximum number of oocytes in week 20 of pregnancy, inside her mother's womb. We are talking about millions. Afterwards, we have a decline that is exponential when she reaches menarche, when she reaches the beginning of reproductive function. She has already 200,000 left. So most oocytes are already gone, most of follicles are already gone. If you compare that to other organs in the body, this is a programmed decline that is much earlier than all other declines. Now, when the engineers who constructed us way back had to construct the female and the male body, they were told, listen, these guys are going to die at the age of 35, 40. So if you have an organ that is going to stop living at the age of 50, you did your job. We changed these parameters, and we need to change our understanding of these parameters. So we know that there are cellular senescence processes occurring in the ovary, similar to other organs in the body. We have senescence markers that are accumulating in the ovary, and we know that these markers are also genetically programmed. We had yesterday a very good talk about it by Dr. Johnson. Now, today, we know that the long-term effects of hormonal balances on morbidity and mortality occur already in young women. We know that women who have hormonal imbalances, for example, a very common disease, polycystic ovarian syndrome, which affects young women and reproductive age women, we know that these women have increased morbidity and have shortened lifespan. We know that, I'll show you in a slide shortly, that young age at menopause goes together with increased morbidity and mortality. And we know that later menopause is going together with health. Who is in charge of the menopause? The ovary. What does the ovary do? Hormonal secretion beyond germ cell and reproduction. So if we just look, and this is known in the literature, if we look at women who have early menopause, and when we talk about early menopause, the definitions vary a little bit, between 35 and 40 years. We have a list, a very long list of morbidities that are connected to that. Risk of cardiovascular disease, osteoporosis, osteopenia, obesity, metabolic, and so on and so forth. You can read it by yourself. Some of them very, very significant. So it's not something that we need to be surprised at, that, again, if the ovary shuts down early, we have a very important impact on longevity. These are two slides that I took pictures of yesterday from Dr. Johnson's lecture, and therefore I'm sorry that they are a little bit fuzzy. But they show very distinctly that you have more cardiovascular disease, you have more CVA, the earlier your ovaries start to work. And on the other hand, a very new study that shows that the later your menopause, the healthier you should be. So, if we ask ourselves, why do women live longer and healthier? There are several theories. Women have maybe a more safer type of life. Women have more social connections than men. Telomeres. But at the end of the day, what I want to show you today, that one of the major culprits, if not the major culprit, is estrogen. Estrogen, a very small molecule. It's a steroidogenic hormone that is being secreted by the ovary. And as I showed you before, when you look at the lower part of this slide, there are evidence-based studies that show the connection between estrogen throughout life, not only during postmenopause. Now, you've seen this slide hundreds of times already, and rightly so. These are the 12 hallmarks of aging, and I'm sure that most of you know them by heart. Why do I show you this slide? For a very simple reason. I don't have the time to elaborate on each of these steps, but if you want, I can communicate it with you. When you look at all these 12 hallmarks, estrogen acts on all of them positively. Okay? And neobarzillitis study was demonstrated by you, was mentioned by you. And again, if you look, there are not many drugs, not many hormones, not many compounds that are known to be as effective as estrogen because of its multiple actions and of course because of its multiple targets to prolong longevity. This is, for example, a slide showing the famous Framingham study. To those of you who don't know that, in the 50s, a study was initiated in a city called Framingham, and the whole population was followed up for for decades afterwards, although the study was at the beginning designed to be shortened. And what you see here very, very clearly, the pink, the lighter bars are the ones of women who are not yet menopausal, and the darker bars are the women who at a certain age are already menopausal. And you see that if women are menopausal below the age of 40, and so on and so forth, they are much more prone to develop cardiovascular disease, the big killer of not us, of all the other people not present at the ARDD meeting. Okay, so if you prevent cardiovascular disease, okay, you improve morbidity, you improve mortality. So this was the answer to why. Then now let's talk about when. When should we start HRT? This is a very important theoretical graph, but there are a lot of studies demonstrating this in animals as well as in humans. When we age, our arteries get clogged up, okay, with age. It happens to all of us at different velocities, at different times. So once the arteries clog up, of course, what happens? the organs become less blood, less nutrients, they decline and they get sick. Once you get to the point where the arteries are very, very clogged up, it takes a very small thrombus to close them, and then you suffer from cardiovascular disease, from brain disease, and so on and so forth. Now, if you take estrogens, you halt this development, because estrogens act on the heart, they act directly on the endometrium. They prevent the development of plaques and of necrosis within the arteries. The earlier, the better. Okay? Remember that. So it shows very, very clearly that early correction of hormonal imbalances can prevent this. And by the way, it happens, I mentioned, for example, polycystic ovarian disease, another big issue that I'm dealing with. What happens there is you have too much androgens, you have too less estrogens, therefore you have a vascular aging, a premature ovarian aging. Now, you say, wait a minute, if this is true, what happens if I start the hormonal replacement later in life? And we know, again, this is based on studies also in animals. If you do it too late, you cannot reverse this procedure. This was, by the way, one of the problems with the famous and infamous WHI study 20 years ago, where women were given hormone replacement therapy, but most of them were beyond the age of 65. At this age, they had already vascular disease, and it was no surprise that they had more cardiovascular disease than the controls, or so this is something that needs to be borne in mind. So the benefits of early start are well documented in humans. As I said before, when you give the hormonal therapy early, you prevent this decline. When people took the WHI study and reanalyzed it, they demonstrated very well that the younger women did much better than the older women. There is a Danish study, we are in Denmark, that examined osteoporosis in a randomized controlled trial. And they showed, although cardiovascular disease was not their first endpoint, they showed in this randomized study that the earlier you started hormone replacement therapy, the healthier you remained. So it's not a surprise that I show you this slide. This is a compilation that was published 2 years ago in the Journal of Cancer, where they looked at different studies and associated them with the start of menopause. You can see here, of hormone replacement therapy. You can see here that, for example, in the first line, time since menopause, less than 6 years. In the second line, less than 10 years, and so on and so forth. And they observed a 40 to 50% decline in cardiovascular disease, the big killer, remember? So it's not surprising that if you take these studies and compare when to start, and you compare mortality, not just coronary heart disease, you arrive at the finding that the earlier you start, women live longer. This is, again, a reanalysis of the WHI study that I just mentioned to you. And you can see here, and don't look at the left side, CE alone and CE-MPA trial. Unfortunately, they used the wrong hormone replacement therapy. But still, this was what was 20 years ago. But you can see very clearly in the green brackets that the all-cause mortality was declined significantly. Another point that is very important, you can see to the right of the red bracket, many morbidities that are decreased. And you can see a big difference between the upper and the lower line, and I'll elaborate on that with estrogen alone, you have a reduction and not an increase in breast cancer. The problem with breast cancer is progesterone. We'll talk about that in a few minutes. So When to start HRT? First of all, I think that every woman needs to be confronted with the possibility. When we see them, when we talk to her, we should tell her, you have a possibility. And that's why I think that gynecology is a very important station in longevity treatments and studies. And when Sipi suggested to me to join, it took me less than a second to say yes, yes, yes. Okay, because I'm very, very clear on the need of gynecological evaluation in women in order to prolong longevity. Now, the best time to start, as I said before, is perimenopausal. And a very important point, I don't think that symptoms are the only indication for hormone replacement therapy. Okay, there are women who are lucky enough and have no hormones and have no symptoms. But still, if they are hormoneless, ovarian hormoneless, you should address the benefits that they could get to that. Of course, you need to discuss with them possible side effects, possible contraindications, for example, thrombophilia and other diseases that I'll show in the next slide. If you look at the recommendation of the menopausal societies around the world, they say you can start it up to 10 years after menopause. I still think the earlier, remember what I said before, the better. Okay, but why not after 60 years? Because if a woman comes to me more than 10 years after menopause, remember the slide about the arteries, she is at a higher risk of vascular problems because of the hypervascularity that estrogen can cause if taken, for example, orally. So we have there our concerns, and if somebody is interested to know what we do with that, it's not part of the lecture, but we are going further to examine that. And it's clear and very well documented that if a woman has early menopause, hormone replacement therapy should be started early at age 35, 40, and so on and so forth. Risks of HRT. Of course, there are two risks that put women more or less into stress. One of them is cardiovascular disease based on the WHI. But as I told you before, the WHI results were skewed because most of these women were older. If you look at younger women, it's less of a problem. However, cardiovascular societies have managed a risk table, and the recommendation is that if the woman has a high risk for cardiovascular disease, you should avoid it. On the other hand, it prevents cardiovascular disease. So it's a problem that needs to be individualized. The other problem is breast cancer. There is an increase in breast cancer by about 20% if you need progesterone. Now, you need progesterone to save the woman from uterine cancer. So it's like many things in life, a trade-off. However, what we do is, if she starts hormone replacement therapy, we are very minded in early and continuous diagnosis of breast changes, and according to that, we feel, and we are waiting, of course, for studies on that we can either detect early breast changes or, God forbid, detect early breast cancer. We know today, it's not something that I wish to anyone, but we know today that the rehabilitation from very early breast cancer is very, very significant. Remember, cardiovascular disease is the big killer, and we need, as physicians who are trying to teach politics, to try to find the right weight for the public and for each patient, N is one, and to decide there how to proceed. So the third question, what type of HRT? There are three possibilities that I show you here, and of course I could speak about that also for days. Estrogen only for women who don't have a uterus, for example, who had a hysterectomy. There are even people who suggest, let's do hysterectomy on all women at the age of 40, 45, and will be easier with the treatment. you need to take into account the dangers of hysterectomy and the downsides of hysterectomy. I'm not there. I'm just telling you, a woman without a uterus needs only estrogen. Combined hormone replacement therapy for women with a uterus, and I'll speak a little bit about yes or no androgens. Now, there are more than two types of estrogens, but again, due to time restrictions, I'll talk only about two major ones. One is 17-beta estradiol. By the way, 17-beta estradiol, for all those who are not reproductive endocrinologists in this room, is the product of the ovary. Okay? The follicle secretes 17-beta estradiol. Therefore, I wrote bioidentical. On the other hand, there is no need for all these millions of dollars being spent on so-called engineered bioidentical substances. You have it. You can buy it in every pharmacy for reasonable amounts. 17-beta estradiol is present either as transdermal or as oral. Transdermal should be the first line of treatment for a very simple reason. It lowers the risk of venous thromboembolism, it lowers the risk of liver changes, and it has been shown to be safer to avoid stroke and cardiovascular disease. In addition to that, I, as a reproductive endocrinologist, am measuring all the time estradiol and progesterone in my infertility patients. So for me to tell the menopausal woman, go and make estradiol progesterone tomorrow morning, and I know where you are, is much better, and I have a closed loop, because symptoms are not a good sign of whether women are well equilibrated. I have women who tell me, listen, I feel fine, I measure no levels because the uptake is very low. I have women who tell me I'm feeling over, and so on and so forth. All the possibilities are there. I think, we spoke about it here, and I'm sure that you'll agree with me, knowing the outcome is always better than trying to guess where you are. Oral estradiol is the second line for women who cannot use transdermal estradiol. It has the downside of liver bypass, but still is much better than, for example, conjugated estrogens, where you have sometimes tens of types of estrogens that you don't know which are working, which are not. Ethinyl estradiol is more for oral contraceptives, not for postmenopausal treatments. What about progestins? I have here several names. It's not comprehensive, but I made a distinction between the first two and the others. The reason being, the others that you see there, medroxyprogesterone, acetate, noethindrone, levonorgestrel, are based on androgens, okay? And they have androgenic activity. We don't want androgenic activity in women in postmenopause, because testosterone and androgens have a counter effect to estrogen, to the estrogenic effect. So if we are talking about which progesterone, again, my first line of treatment is micronized progesterone. That in Israel, you have it only orally. In other countries, there are also patches with micronized progesterone. You can either take it orally, transdermally, even vaginally, although it's not very sympathetic for the woman to go years and many years with vaginal suppositories. It has endometrial protection. That's what I want. It lowers the risk of breast cancer, and it has been shown that this is better than the other progesterones for the avoidance of breast cancer and cardiovascular disease. And therefore, it should be the drug of choice. In addition to that, progesterone causes relaxation and a little bit tiredness. And therefore, I advise my patients to take it before sleep in order to prolong sleep. Postmenopause, we all are aware of the problems of sleep in the postmenopause. An alternative, an oral alternative, is dydrogesterone. Again, it has a low profile, a good profile, and actually I cannot say anything. I prefer micronized progesterone, but it's more of my personal preference. Dydrogesterone is also quite a good drug. What about androgens? Now, the ovary secretes androgens. By the way, during the menstrual cycle, androgens peak around ovulation. Why? Libido. Evolution is sometimes clever. Okay, so you have estrogens as a factor and as a secretion of the ovary. Androgens have good benefits, or could have good benefits. Bone density, muscle mass, mood, libido, cognitive function. However, on the other hand, they have quite a lot of downsides. They neutralize part of the estrogenic cardiovascular effects. They have maybe an effect on breast cancer. So if you are confronted with the need, I personally don't give testosterone routinely. But if I have a patient where I feel that testosterone could help her life, for example, with muscles, for example, with libido, I give it very, very, how do you say, very, very gently, okay? And again, the androgen is testosterone. Testosterone is measurable. So I can measure testosterone throughout the treatment and say, wait a second, you are too high, wait a second, you are too low. And so the answer about androgens is not there, but it needs to be on the table. So at the Sheba Longevity Center, and there was actually a question to Tzipi in the morning whether we prescribe women HRT. Yes, but only after what I said before. Discussion, need. Some women come to us with already treatments that we are not very happy about. We tell them why they could improve, but on the other hand, sometimes improving is extreme. So if we start new, this is the protocol. We start with continuous transdermal estradiol patch. I told you already before why, or gel. And we start with a low dose and increase it only if necessary according to our exams. Same with micronized progesterone. What about alternative treatments? I'm a little bit skeptical about alternative treatments instead of hormones. I think that our task needs to be to do what the ovary did until its demise. And therefore, I rely more on these two drugs. Remember the slide 10 minutes ago that I told you about cellular senescence in ovarian aging? You saw the first two sentences. Look at the last one. Could senolytics or ovarian manipulations prolong ovarian function and improve female health? Remember that I told you about the engineers that had to have ovaries for the first 50 years, which was enough. Today it's not enough. And interestingly, there are more and more people acting on prolonging ovarian life. There was even, maybe some of you saw it a month ago in the New York Times, a big issue on could delaying menopause be a key to longevity. So what could we do? Just in animals, if you take old mice and transplant them young ovaries, you prolong their longevity, you avoid morbidity. Okay? There are several companies that are acting on prolonging ovarian life, for example, by giving senolytics and by trying to overcome the age of the natural age of the ovary. There is something that we call already for many years the ovarian clock. The ovarian clock is the one that tells the follicles to start growing, and at the end of the day, if you stay without follicles, the ovary dies. Now, if we could, and I'm sure that it'll happen over the next 5 to 10 years, because I'm aware also in our center, people are working on trying to find the factors that are governing the ovarian clock. If we could understand the genetics that are governing the ovarian clock, we could maybe therapeutically enhance ovarian life. For example, as I told you before, rapamycin is being examined, whether it could also prolong. Something that was spoken about yesterday in one of the lectures. We had one lecture on cryopreservation and one lecture on ovarian life. I'm sure, as far as I can be sure, that one of the possibilities could be the one that I just told you about in mice. Come to women who are interested at their age of 35, 40, after they finish reproduction, and tell them, or they'll tell me, listen, I want to preserve my ovarian function, take out a little bit of my ovary by laparoscopy, freeze it, put it back once I'm menopausal. The longest woman who had this done had 25 years of ovarian function with the fragments that were replaced. So this is something that, in my opinion, will win the race in similarity to what I do to young women who are not yet in a relationship or don't want to be pregnant at the age of 30, 35, where we do oocyte retrieval and oocyte freezing. In conclusion, the ovary, I hope I persuaded you, is a geroprotective hormonal organ. Our task is to therapeutically prolong its important adequate function today with hormones, maybe tomorrow with other technologies, in order to improve female healthy longevity. Thank you very much.